Welcome to VetCare, your channel for practical veterinary learning. Today, we're discussing diuretics. These drugs help animals get rid of extra water and salt from the body by increasing urine production. Most diuretics work by stopping sodium from being reabsorbed in different parts of the nephron, which is the kidney's filtering unit. When sodium stays in the urine, water follows it to keep the balance, which leads to more urine being made. Diuretics are mainly used to treat swelling caused by fluid buildup, called edema, and high blood pressure, hypertension, in animals. The kidneys control how much urine is made and keep the right balance of ions in the body by either reabsorbing or getting rid of substances along 5 main parts of the nephron: the proximal convoluted tubule, the descending loop of Henle, the ascending loop of Henle, the distal convoluted tubule, and the collecting tubule and duct. The proximal convoluted tubule reabsorbs nearly all of the glucose, bicarbonate, and amino acids, and about 2/3 of the sodium. Sodium is moved into the kidney tissue. An enzyme called carbonic anhydrase plays a role in helping the body reabsorb bicarbonate. This part of the nephron also gets rid of waste products such as uric acid, creatinine, and some veterinary drugs. Carbonic anhydrase inhibitors such as acetazolamide work in the proximal tubule. They block carbonic anhydrase, which normally helps turn carbon dioxide and water into carbonic acid, which then breaks into hydrogen and bicarbonate. By blocking this process, these drugs reduce hydrogen release and sodium reabsorption, leading to a mild increase in urine output. They also cause the body to lose more bicarbonate, which makes the urine more alkaline and can lead to a condition called metabolic acidosis. In veterinary medicine, carbonic anhydrase inhibitors are used to treat eye conditions like glaucoma by lowering eye pressure, and to reduce pressure from spinal fluid. Side effects include metabolic acidosis, low potassium, kidney stones due to alkaline urine, and the risk of ammonia buildup in animals with liver disease. In the descending loop of Henle, the fluid that passes through the tubule starts with a normal salt level. But as it goes deeper into the inner part of the kidney, which is very salty, water leaves the tubule due to the salty environment outside. This makes the urine more concentrated and is part of the kidney's water-saving system called the countercurrent mechanism. Osmotic diuretics work in this area by preventing water from being reabsorbed. Main drugs: mannitol, urea. These are freely filtered substances that are poorly reabsorbed in the nephron. They make the tubule fluid more concentrated, so water stays in the tubule, leading to more urine. Osmotic diuresis. Mainly promote water excretion rather than sodium excretion. Therapeutic uses: prevent kidney damage by maintaining urine flow after toxic ingestion or shock. Treatment of cerebral edema. Acute renal failure, preserving kidney function. The ascending loop of Henle is impermeable to water, but it actively reabsorbs sodium, potassium, and chloride. It uses a special channel called sodium-potassium 2-chloride ion cotransporter. Magnesium and calcium also move out into the kidney tissue. This section reabsorbs about 25 to 30% of salt and keeps the medulla salty, helping the kidney concentrate urine. Loop diuretics, strong water pills, act here. Loop diuretics, also called high-ceiling diuretics, include furosemide, bumetanide, torsemide, and ethacrynic acid. These drugs block the sodium-potassium 2-chloride ion cotransporter. They cause large amounts of urine output and are the most effective diuretics available. Key actions: increase excretion of sodium, chloride, potassium, calcium, and water. Unlike thiazides, loop diuretics increase urinary calcium. Can increase renal blood flow by enhancing prostaglandins. NSAIDs may reduce their efficacy by inhibiting prostaglandin synthesis. Uses: treatment of acute and chronic edema in heart failure and renal disease. Acute pulmonary edema. Hypercalcemia, promote calcium excretion. Hyperkalemia, increase potassium excretion. Adverse effects: ototoxicity, hearing loss or vertigo, especially with ethacrynic acid or aminoglycosides. Hyperuricemia. Volume depletion from diuretics causes the kidneys to reabsorb more uric acid in the proximal tubule, leading to increased uric acid in the blood, lead to gout. Hypovolemia, rapid volume loss can cause hypotension and arrhythmias. Hypokalemia, due to increased potassium loss, can cause alkalosis. Hypomagnesemia, especially with long-term use. The distal convoluted tubule is also impermeable to water, but it reabsorbs about 10% of sodium chloride using a sodium chloride transporter. Thiazide diuretics block this transporter, which reduces sodium reabsorption and increases sodium and chloride excretion. Calcium is also reabsorbed in this area in exchange for sodium, and this process is controlled by parathyroid hormone. Drugs. Hydrochlorothiazide and chlorthalidone are widely used, with hydrochlorothiazide being more potent. Chlorthalidone lasts longer and is used once daily. Metolazone is stronger and effective even in kidney failure. Indapamide is lipid-soluble with minimal diuretic effect but strong blood pressure lowering, and it is less likely to build up in kidney disease. Key actions. Unlike loop diuretics, thiazides reduce calcium excretion by promoting calcium reabsorption in the distal tubule, which may protect against bone loss. Like ACE, angiotensin-converting enzyme inhibitors. They may be added to loop diuretics in heart failure to boost fluid removal. Thiazides also help manage hypercalciuria by reducing calcium in urine. Side effects: hyponatremia, hyperuricemia, risk of gout. Hypercalcemia. They also cause loss of potassium and magnesium, so monitoring for hypokalemia is important. The collecting tubule and duct adjust the final composition of urine. Special cells called principal cells reabsorb sodium, potassium, and water. Sodium enters the cells through specific channels, and is then pumped into the blood using the sodium-potassium pump. A hormone called aldosterone increases the number and activity of these sodium channels, helping the body hold on to sodium and get rid of potassium. Another hormone, called antidiuretic hormone or vasopressin, increases water reabsorption in this part of the nephron, which helps the body conserve water. Potassium-sparing diuretics work in the collecting tubule and help remove sodium while keeping potassium in the body. These drugs are usually given along with loop or thiazide diuretics to prevent potassium loss, but they should not be used in animals with kidney failure because they can cause dangerously high potassium levels. There are two types of potassium-sparing diuretics. The first type, aldosterone antagonists, includes drugs like spironolactone and eplerenone, which block the hormone aldosterone. This reduces the activity of proteins that cause the body to hold on to sodium and lose potassium. These drugs help remove extra sodium and water while keeping potassium levels stable. They are used to treat swelling caused by too much aldosterone, as seen in liver disease or kidney disorders, to improve survival in heart failure by protecting the heart, to manage difficult-to-treat high blood pressure, and to control fluid in the abdomen, ascites, in liver disease. The second type of potassium-sparing diuretic sodium channel blockers includes drugs like amiloride and triamterene, which block sodium channels directly without involving aldosterone. These drugs also help keep potassium in the body but can cause high potassium levels. Combined with thiazide or loop diuretics to prevent hypokalemia. Triamterene may also lead to kidney stones and raise uric acid levels. Thank you for watching VetCare. If this video helped you understand veterinary diuretics better, please like, share, and subscribe for more simple and clear veterinary pharmacology lessons.